Okay, that stopped my recording. I apologize. So, aplastic anemia, it's a bone marrow failure resulting in pancytopenia, and it can be caused primary, either it's congenital, Fanconi syndrome. This is a rare inherited disease. Or it can be secondary, which basically the person got exposed to something toxic, had an infection, got a medication, or for some other reason where it destroyed the bone marrow and it's not working correct anymore. How do we diagnose this? Obviously, what do we want to look at? The bone marrow. The bone marrow is not working. That's what we look at. And also their clinical manifestations. So leukopenia, low blood cells, low white blood cells, thrombocytopenia, low red blood cells. They get the purpura, the petechiae. Their bleeding time is increased. They have fatigue because, again, their red blood cells aren't working the way they're supposed to. They're pale. They can get headaches and palpitations. So whether the patient was born with this or whether they acquired this, they get immunosuppressive therapy, typically drug therapy. And the only treatment is a bone marrow transplant. Your job as the nurse is to prepare these children and family for the procedures and help them with things like preparing them or preventing bleeding, preventing any infection. They oftentimes have to get blood products, so educating the family on the blood product they're getting, any side effects from that blood product. And because these patients are extremely sick and extremely fatigued, they often don't want to do much, so we really want to encourage mobility when we can. Encourage them, even just their ADLs, they tend not to want to take care of themselves. And again, education is really important for these families.
So when you do a bone marrow transplant, how much do they need to do a transplant? Like
Bone marrow?
quantity?
I don't know specific quantity of the bone marrow. I don't know that question. I can look it up.
Do they just put it in one area
No.
and then it grows from there?
Typically, yes. They take out their bone marrow and they put new cells in that are going to grow healthy cells because they have, ineffective bone marrow and they're trying to replace it with healthy bone marrow that's going to grow right.
And once they have the bone marrow transplant, is this done? Like, are they healed?
Yes, with anything it can remiss, but technically they're healed, but it's a big procedure, and especially the Fanconis, which is very rare and inherited. These are sick kids. They oftentimes don't do well even with the transplants. Acquire does better, but yes, in theory, once they get the transplant, that's their treatment.
So why do in the other anemias we encourage rest and this one we encourage mobility?
They do need their rest, but because it's such a severe anemia, they'll just lay there all the time. And why we want them to rest, we don't want them to be just slugs. We want them to be able to take care of themselves. We want them to be able to do simple ADLs, get up and go to the bathroom, because they won't give themselves baths, or they'll opt out of it. Instead of getting up to go to the shower, they'll just say, just give me a bed bath, or they can become very dependent, and we want to encourage as much normal growth and development and as much normal dependence as possible within their disease process.
about the palpitations?
Headache.
Headache.
Is bone marrow rejection common or?
Mhm. Yeah. So that one's pretty straightforward.
Now, if they have the bone marrow transplants, you know, and if they're readmitted into the hospital, do they need to be like in a room by themselves for like 5 years and that
Yeah.
kind of protocol?
Every hospital has different protocols, so you would just follow your hospital's policies and procedures. But yes, you need to protect against infection, and the family needs education on that. That we don't want to shield them from life per se, but we don't want to do things that would increase their chance of infection. Like if you knowingly are sick, don't go in the, you know. All right. So hemophilia, it's an X-linked recessive gene. So it's linked to the female gene. So a dad can pass the gene to the children to be carriers, but the dad can't have the disease. And I'll show you that in just a second. But basically with hemophilia, there's some kind of deficiency in one of the clotting factors. Most typical is factor VIII deficiency. That's like 80 to 90% of all hemophilias have a factor VIII deficiency. This is also known as hemophilia A. There can be a factor IX deficiency, which is hemophilia B, or the Christmas disease. And Miss Keeney, do you know why it's called Christmas disease? I have no idea why.
I honestly don't.
Okay, I was gonna, if someone
I'll
knew.
look it up.
Yeah, I don't know, but it's less common. It's only about 5 to 10%. And then there's von Willebrand's, where there's a deficiency in the clotting factor. It can happen in girls or boys, and it's typically only brought on when the child has a stressful event.
And it goes away.
They have it, but they only have symptoms during like stressful events. It's a much, if you want it like this, hemophilia A is sicker. Von Willebrand's is better. This one I can kind of compare. All right. So it's hereditary. It's X-linked. So if we look at that box.
The first child they studied, his last name was Christmas.
Oh, there you go. All right. So for this one, you have a mom that is a carrier, right? You see the A right there? So this is mom up here. Females are XX, right? Mom is a carrier, so she's got the little hemophilia gene. All right. Dad has the disease because he doesn't have a healthy X. Does that make sense? So his X that has the disease, A, he doesn't have a normal X to counterbalance it. So with a mom that has the trait and a dad who has the disease, you have a 25% chance of having a daughter that has the disease. You have a 25% chance of having a daughter that has the trait because she's got a healthy X, right? And this is X-linked recessive.
Are they gonna ask this on the test?
You need to understand it.
Okay.
And then there's, what?
Is this a question?
Yeah. And then the XY, they have a 25% of having a son who has the disease, right? Because they don't have a healthy X to counterbalance. So if the son gets the affected gene, they have the disease. And then they have a 25% chance of having a son that has no disease. or no trait. If you look at it and only the mom has the trait, but the dad is healthy, then you're only going to end up having carriers, right? I'm sorry. Your daughter will only be the carrier because you have a normal X and XA, normal XX, but you do have a 25% chance of having a son that has the disease. So if the mom's the carrier, no matter what, you have a good probability that your son could get the disease. It's much harder for girls to get the disease because they need to have a mom and a dad that both have it. Does that make sense? If not, tell me and I can go over it again. I'm getting a confused look.
Could you do it one more time?
But the drawings and everything will be in your lecture if we like release it.
Yep, I'm recording and it's in my lecture. I think that's Bree's way of telling me move on.
I'm gonna have to listen to that like 5 minutes.
Yeah.
so
No,
I
that's
can
okay.
do it over.
So no, that's okay. So basically if you look at this with the XX, so if the mom has the trait, right? Because she's got a normal X and
So the A is the trait.
the A is like the trait.
Okay.
And then you have a dad who's got the disease because he doesn't have a normal X to balance it. You're going to have a daughter with a 25% chance of having a daughter with the disease, 25% chance of having a daughter with the trait, 25% chance of having a son with the disease, and 25% of having a normal son.
And if they have the trait, they just carry it. They don't.
They just carry it.
So that's
Wait.
the only way for a daughter to get it.
I'm sorry, what?
That's the only way for the daughter to actually have the disease.
Yes.
Because
Is
if the dad's healthy, then there's no 2X.
exactly. Yep.
I have to say, in my 46 years of being a pediatric nurse, I've never ever seen people.
Yeah, it's mostly males. Because it's X-linked recessive, you mostly see males that get it because it's a much easier probability of them getting it. Because they don't have that healthy X to balance it out.
One X, either they have it or they don't. Both.
Yeah.
Male.
Yep. So if the dad is healthy, then the daughter's not going to get the disease, but there's still a probability that the son could. Right, that's right here.
Yes,
Okay?
it's in there.
All right, does that make a little more sense? It is kind of confusing. Even I had to practice it out. All right. So let's look at how we diagnose. Obviously, clinical manifestations, which we're going to get to. Genetic testing, genetic history, and clotting studies. So this is where clotting studies become important because different PT and PTT measure different clotting factors. PTT measures factor 8. So that's why it's important to look at PTT specifically when looking at hemophilia. These patients will have normal PT, normal fibrinogen, normal platelets because those aren't affected. Remember, it's a factor 8 deficiency. So the only factor that's deficient is number 8, and that's what PTT measures. The rest of their blood work will look normal. These patients can get bleeding into the tissues. They can get hemarthrosis, which is bleeding into the joints. They bruise easily. They get nose bleeds, mouth bleeds, chest bleeds. They're at higher risk for intracranial hemorrhage. If they do have bleeds into the joints, they have painful range of motion. And these patients oftentimes, especially for boys, they get diagnosed because they go to get their poor little circumcision and they can't stop the bleeding after the circumcision. Also, for kids that maybe if it's a female and she's into singing and she hasn't had a lot of contact and there's not been a lot of reason where she maybe had an issue and she goes for her first dental procedure and she bleeds a lot. So treatment for these patients is when they're having an episode or when they're having a bleeding episode, I should say, they get factor replacement. We give factor 8. They also can get DDAVP because it increases the plasma factor 8. And that's that synthetic vasopressin. If there's bleeding into the joints, we give the corticosteroids to help decrease the inflammation because once they have all that blood in the joint, it does become very painful. We give Tylenol. Why wouldn't we give NSAIDs?
Increased bleeding.
Increased bleeding, right? Also, be careful with what are we not going to give? I heard it, Karen. Aspirin. Yep, aspirin. So we want to be careful with NSAIDs, no aspirin, because we don't want to make bleeding worse. These patients are already having problems bleeding. These patients really need a lot of education about preventing bleeding. So we as nurses, we don't give rectal suppositories. We don't get rectal temperatures. We don't give IM injections to these kids because we're going to cause them to bleed. We also are going to educate these parents. These are not going to be the football stars. These are going to be like your theater people. All right. We don't want to cause anything that's going to increase their risk of like an intracranial hemorrhage or, blood into the joints. That doesn't mean that these children should never exercise. A lot of parents take it as our children aren't going to move. We still want them to be active. Remember their children. Remember their developmental needs. They still need to be active. I don't know if you guys have ever heard of Boggy Creek Camp. It's over on the other side of Florida, and it's a camp for children with chronic illnesses. And they have it over the summer, and so they staff nurses full time. And so when I was in nursing school, we got a chance to go down there and be at a camp, and I went to hemophilia camp. And I swear to God, I just ran around with gloves all day long, like chasing children because I was terrified that they were going to run into something or like bleed to death. So, but it was absolutely terrifying. But it's this awesome camp that lets kids do things like go to summer camp that they don't normally get to do, but within a safe environment. So we want to encourage parents to let them go play and let them do things, but within, safe parameters. They might need physical therapy. They need lots of emotional support. When they see their child just bleeding, parents get freaked out. I had one parent hit the floor, they were bleeding, it was bad. Discharge planning for the child, all that education we talked about. And the big thing, if you do have a child that's bleeding into the joint, you do need to treat it so we can stop it because the more swollen the joint gets, the more decreased motion, the more pain. So ice it. Do we ever use heat? No. We don't want to use heat. So sickle cell, heat, hemophilia, no. We want to vasoconstrict. We're going to apply direct pressure. We wrap the ACE bandage around it. Apply direct pressure to kind of keep it from spreading the blood into the joint. We need to elevate it, right, so it gets reabsorbed. During times of bleeding into the joint, that's when we do limit motion because the more motion we have, the more chance of the blood increasing. And then pain management. All right. Any questions? AIDS. This is the human immunodeficiency virus, HIV. That virus targets CD4 T lymphocytes, and it basically eliminates all cellular immunity. So, when this disease was first discovered, it used to be a death sentence. Now it's just considered a chronic illness, just like kidney disease. I remember when I was first a nurse, when we had a patient with AIDS, it was a full protected, like, we wore a mask, we wore a hat, we wore gloves, we wore a gown, we wore like booties over our shoes. People were terrified. And I mean, it had been out for years when I came. That was 15 years ago, but even within the last 15 years, it's come a long way. Now what do? Standard precautions, right? It's just gloves. So we really have come a long way in helping these patients maintain health. I'm sorry, I forgot to press. Where it's now just a chronic illness versus a death sentence per se.
Instead of gloves or T.
Targets CD4 T lymphocytes. And it basically decreases or completely eliminates all their cellular immunity. So how do kids get it? One, from their moms, perinatally. And if an HIV positive or AIDS mom does have the disease, then we can give medicines afterwards, but they can get it through breastfeeding if a mom doesn't know that she's been exposed or has the illness or disease. It can be obtained from blood products, transfusions, although that's really rare now because they do test the blood so frequently. And from high-risk behaviors, adolescents who are sexually active, and more sadly, for a child that's been molested by someone who has it. So.
An interesting thing about this is because the factor VIII, which we hemophiliacs with, is a blood product, of course, that we had thousands of hemophiliacs infected with HIV secondary to the factor VIII until we started the blood story.
Yeah.
And the other funny thing I'll tell you about HIV is I saw the first patient who was suspected of HIV probably about 1980 at All Children's Hospital, Atlanta, and nobody knew what was wrong with this 2-year-old. But we were right down the street from the CDC, and you know those CDC doctors are the ones who write the guidelines, right?
All right, so how do we diagnose a child? The ELISA or their Western blot. However, these can't be used until the child's 18 months of age. So a PCR can be done when the child's 1 month old. And we monitor CD4 counts to see the progression of the illness, to see how severe it is.
What did you say PCR for the age?
1 month. So what are we going to see clinical manifestations? They kind of get like this flu-like illness. They're just kind of sick. They might have some failure to thrive. They might get recurrent infections. This might be the child that has ear infections every month. Although any parent will probably say their child had ear infections every month. But recurrent diarrhea. They get oral thrush a lot. So they have a lot of infections, but they also get infections that most kids don't get, like thrush, frequently. Mm-hmm.
Since they don't have immunity, so if they get like a cold, does it go away or is it absolutely?
No, they just get really sick from the cold because their body can't fight it off. Yeah, and that's what most of the time they present, even if they're not diagnosed right away. All of a sudden they get sick and the parents are like, I thought it was just a cold, and then it's been days, a week, or longer, and they're not getting better. Or they just keep getting these weird recurrent infections like thrush, and they get diagnosed. Or they get diagnosed with PCP, which my students should know because we talked about it. and post-conference, is the pneumocystitis carnea pneumonia. This is what used to kill, well, just PCP. It's bad pneumonia. Just write bad pneumonia. This is what killed the majority of patients with HIV. They had a very high morbidity and mortality rate because of it. But now with prophylaxis, it's gone down extremely low.
Is it only transmitted with blood products or mucus in saliva?
All these ways, right here. So they get it from their mom, they can get it from breastfeeding, they can get it from blood products, or sexually transmitted.
But if a kid is like having a cold and he sneezes, that should be good.
You should be fine, yes. Yeah. All right, treatment. There's no cure for this disease. We just want to protect them from getting sick. Again, this used to be a very high morbidity, mortality, and now it's more like a chronic disease. We monitor their CD4 lymphocyte counts. We want to prevent and treat any infections. And these children should be immunized. It's really important to immunize them because we want to protect against all these childhood diseases. However, you have to be careful with live vaccines. What are your live vaccines? MMR and varicella and intranasal flu. Okay? Antibiotic therapy when appropriate. We just don't give antibiotics anytime, but if the child needs it, we give it. We monitored the disease progression and how it's responding to therapy. These children are often on multiple medications, multiple combinations of medications, and we want to see, are they doing well? Are we preventing infection? Are they growing? Are they healthy? Normal growth and development? Are they not responding?
What was the third live vaccine?
Intranasal flu. When you get IM, it's not live, but there is a version, although they're not recommending it for healthcare providers or anyone who's at risk because they're saying it's not very effective. And you as healthcare providers should never really get the intranasal flu because you will shed it and then you're shedding it to all your patients, and that's the opposite of what we're trying to do.
Like a nasal spray?
It's like Afrin. You just
I thought that they did away with that.
it's
This year, right?
they're not. I think they still have it, but they are not recommending it. Yeah. They do in the military? Okay, yeah. I think
it's the first season they have recommended
not to. Yeah, this is the first season they've recommended not to do it. Previously, they said they were equally effective, but we as healthcare providers, or if you are around anyone that's sick, should never do it because then you're shedding the live disease.
The one they gave to the kids that was nasal, was that also live?
Yes, the nasal for kids or adult was live. So these kids need nutritional management and making sure that they're getting everything for normal growth and development. Leukemia, it's a malignant disease of the bone marrow and lymphatic tissue. So they have the immature white blood cells that proliferate, and basically they infiltrate and compete with normal cells. So this malignant disease of the bone marrow and the lymphatic tissue. And proliferation of the immature white blood cells. Prognosis is related to the age of onset. If it's diagnosed less than 2 years of age or greater than 10 years of age, they have a poorer prognosis.
So if they get it between 2 and...
They have a higher chance of survival. Girls tend to be more than boys. And also, if they have a low white blood cell count, and initially, they have a poorer prognosis. So types, there's ALL, acute lymphoid leukemia. We don't know what causes it. We don't know why these cells kind of proliferate and take over. But the peak onset is usually 2 to 4 years old. But it does have an 80% survival rate. There's other forms like AML or ANLL, which is acute myeloid or acute non-lymphoid leukemia. They're very, again, etiology not quite understood. They peak around the same ages, but their survival rate is less, about 50%.
We have to do morphology.
No. So how are we going to diagnose these patients? History, their clinical manifestations. We're going to look at their CBC. They're going to be anemic. They're going to have those immature leukocytes. They're going to be neutropenic. They can do a bone marrow aspirate to look for immature or blast cells, or lumbar puncture. So basically, they get clinical manifestations because there's an infiltration of the bone marrow, right? These immature white blood cells are kind of infiltrating and competing and taking over. So they become anemic, their red blood cells are down. Like we said, they get infections a lot because their white blood cells and their neutrophils are down. They'll have fever, bleeding, again, because they're competing. These immature white blood cells are competing with everything. So the platelets are down. Again, they're going to be pale, lethargic. They're not anorexia. They don't want to eat. I mean, it's a whole slew of symptoms, and they're all written down on your chart. Large joint or bone pain, liver or spleen enlargement, lymphadenopathy. They come in with just these vague symptoms, and they've been sick for a while. They're vague symptoms. We can't really figure out what's going on with them. They do a CBC, and they see that, you know, their white count's down, their platelets, everything else, and they get diagnosed. Vomiting, irritability. They could get fractures, stiff neck, back pain, or other malignancies. So they're treated with chemotherapy. And the chemotherapy is, they often get admitted to the hospital, they get a port placed, they get their chemotherapy, and it's really rough on the child and the family. The chemotherapy makes them super, super sick. So you need to make sure that you're giving antiemetics prior to them getting their chemotherapy so that they keep up their nutrition and keep wanting to eat. They can get radiation on the cranium if needed. You're going to prepare this child and family for their therapy, for their prolonged hospital stay. Mm-hmm.
With chemotherapy, Dr. Daniels, do you use reverse isolation?
Yeah, like if they go out into the, what's so funny?
Test question.
Oh.
Well, I mean, for this too, I'm just wondering, like, do you, not really trying to.
Yeah, no. No, that's okay. With the,
Or
you,
what do you do?
yeah, it depends how sick they are, what their ANC is like, how well they're able to fight. They're often on reverse isolation, meaning that if they go out, they wear a mask, or if their parents come in, they may need to wear a mask while they're there.
So that's what the reverse means, like the.
Yeah, like
Okay.
it's not that reverse means normally we're protecting ourselves
Okay.
from getting an infection.
see.
Reverse means we're protecting them.
Okay.
Yeah. We want to relieve any pain. And we're going to prevent complications of this myelosuppression. With chemotherapy, one of the big factors is they get bad mucositis. They have lots of sores and breakdown in their mouth. So they have nausea, vomiting, anorexia. They don't want to eat. You need to be really vigilant about getting good mouth care for them, getting mouth solutions that they can, like that swish and swallow with the lidocaine and Maalox, so that they can protect against their mouth. Constipation. Manage any problems of the drug toxicity and provide a lot of emotional support. Oftentimes they come in for their chemo, they get to go home for a bit, they come back for chemo. When they may get better for a little bit, they may go into remission. So this is not just a come in once and be done. So the parents need to understand that this might be involve several weeks, several months, even a year of treatment to get these kids better.
What are the chances of them? Are the chances higher of them getting cancer in the future? Like,
There's speculation that the way we eat and, toxins in the environment and this and that yes, it's going to increase the chance of cancer, but there's no real studies yet to prove.
but I'm saying like if they have leukemia as kids.
Oh, leukemia, I'm sorry, I misunderstood your question. I don't know that. I don't know if I know I worked with a nurse practitioner at All Children's for 10 years. I didn't even know she had ALL as a child, and she was completely healthy. I mean, that woman smoked like a chimney, and and she partied like everybody. I mean, she was a fun girl, and and then she did calm down. She ended up getting pregnant, had a baby, and she breastfed. So she lived a pretty normal life. And people that I know that I find out that have had cancer, I'm like, oh, I didn't even know, because it's not anything long term that you can see. Now, as far as exact percentages on increased risk, I don't know that. I'd have to look it up. But
Because I had a patient that had cancer in the 70s, and then she got pain. He's like, the doctor's saying that might be related, and I was like.
they do
was
think that
30 years
some
ago.
patients, their bodies are more at risk for whatever reason. Their cells are more easily to morph into malignant cells, and why that is, we don't know. And there are some cancers that you're more likely to get them again, but as far as having ALL and getting another one, nothing that I know of. There's not an increase, but I don't know for sure.
Should we know how to calculate absolute neutrophils?
I don't think so, Ms. Keeney. They don't need to know how to. Yeah, I think that's beyond the scope of this. What you guys need to know. Just understand that with ANC, it tells your body's ability to fight infection. So if your ANC is low, it means that your body's having a harder time fighting infection. So they'll take an ANC with leukemic children who are getting chemotherapy, and if their ANC is too low, they may, instead of initiating the new chemo, wait until they build up that child's immune system better. Or their ANC will be low so that they know that they have to implement more protective mechanisms or precautions, then that's when we would do the reverse isolation or making sure no sick contacts. And these are the kids where you're not going to bring fresh flowers or like fruit from the market. You're going to bring them a stuffed bear or a balloon.
Yeah.
All right, and last but not least is Hodgkin's lymphoma. And this is a malignant disorder of the lymphoid system. So it typically arises in a single lymph node. And it's more prevalent in your adolescence. Or like in an anatomical group of lymph nodes. So if you're 15 to 19-year-olds.
What's that first word?
Arises in single lymph node. Yep. Why does this happen? We have no idea. They think that it might be some combination of genetic, viral, environmental, whatever, but they're not 100% sure why these kids get it. They're diagnosed by labs, CBC, a lymph node biopsy. They're looking for the Reed-Steinberg cells. These kids get staged 1 through 4, or A or B, and I believe that's, is it 2610 for those who have their book? It's box 2610 in your wand.
Yeah.
Okay.
What stages?
Yep. That might be the old.
Table 26
26-2. You can get a bone marrow aspirate.
No, that's not right. That's wrong.
Oh, no 26-2.
There's a table, 26 2, and it shows.
It's a no.
Okay. There is a box in your book that shows you the staging.
What about the Ann Arbor staging system? Is that what it's on for? It's like A or B or.
Yeah. And just know that they do stage. I wouldn't get too focused on all the exacts with it. Just know that there's different staging for the Hodgkin's disease, which basically just shows the different severity of the disease. They can get a chest x-ray, and then they often get a CAT scan or PET scan of the neck, chest, abdomen, pelvis, because this disease can spread to other lymph tissue.
And what was BMA? What that stand?
Bone marrow aspirate.
Oh,
You normally get me so good.
I know. I should have gotten it.
All right. So the big clinical manifestation as these children, it's typically a teenager, and they present with an asymptomatic, non-tender, enlarged cervical or supraclavicular node. It's called a sentinel node. This is like the main thing. They've got this node. They think they just got sick. They can feel it. It doesn't hurt them. It doesn't bother them, but it's just there. Oftentimes they'll come in. The PCP will put them on an antibiotic. The antibiotic will do absolutely nothing for the lymph node, and then they go in and get further testing like CBC or a biopsy and find out that it's the Hodgkin's lymphoma. They can have additional symptoms. They can have weight loss, abdominal pain, anorexia, pruritus, cough, night sweats. But the main symptom that they almost always present with is that asymptomatic lymph node. Treatment. These children have really good survival rates. They treat with chemotherapy. It's the same with leukemia as far as precautions, and they also get radiated. They do need lots of follow-up care. They often have a PET scan or CAT scan after treatment to make sure that it hasn't spread or reoccurred. We need to prep these families, just like with the kids with leukemia, you know, on the chemotherapy process and about side effects. They need, you know, family and child need support. This often happens in adolescents. What are adolescents concerned with? Body image, right? So they might get a port for chemo. They might lose their hair. They might, you know, have surgery scars. So there's a lot of emotional support that needs to go for these families. And also for a parent, they think they've gone, you know, you kind of You get so far in life and you think, oh, I've made it to the teenage years. I've got a healthy kid. I've got nothing to worry about. And now you might lose your 15-year-old. So it can be very scary for these parents. It can be a drain on them emotionally. If they're working and they can't be there with their child, just like with everything else with kids, those are the things we need to think about. But developmental needs. And like I said, long-term survival rates are really excellent. If it's caught early, the 5-year survival rate is 90%. And even for advanced stages, if it's caught later, there's a greater than 65-75% chance of survival, even if it's caught late. And I believe this is one of, I don't know, it's in our slide, but in our lecture, I think it's a child of a old instructor. And I believe she had Hodgkin's lymphoma and survived and did well. I honestly have no idea who this person is, but or why they're in our slide. But from what well, what I think is that this was a child of a instructor that with the disease. So, so do you guys have? That's honesty at its best, right? So do you guys have any questions or concerns? Anything? I know, lots of concerns. I'm sorry. I shouldn't say concerns. I'm going to stop recording, so I just want to make sure no questions before I stop.